Hello, everyone. I believe we are ready to begin. Good morning. I have the privilege and honor to introduce the presenter, Mona Zuffante, for our breakout session this morning, titled Winnebago Tribe Public Health Accreditation, Doing It Our Way. She currently holds a MPH and is the Public Health Administrator for Winnebago Tribe of Nebraska. So ladies and gentlemen, without further ado, Mona Zuffante.
All right, thank you very much. We'll go ahead and go to the next slide. So as you heard Dr. Warren speak yesterday, I would be remiss if I didn't, being a student, that acknowledgement of the people is so important. So I humbly make a land acknowledgement. I would like to recognize and acknowledge the indigenous people of this land, the Poncas, the Santee Sioux, the Omahas, and the Winnebago tribe of Nebraska. We are gathered today in the various areas within the state of Nebraska and maybe outside of Nebraska. And I wanted to acknowledge the indigenous people of the state. They have been the stewards through generations for the lands, the waters, and now in what is now the state of Nebraska. We honor and respect the enduring relationship that exists between the peoples, the nation, and this land. Next slide. So since I work in Winnebago and for the tribe of Nebraska and the Winnebago Public Health Department, this will be centered around them. And of course, we always have to start where we come from because it is the basis of who we are today. So the Winnebago tribe back in the 1620s, had split into two bands. And some of the tribes stayed in Wisconsin and the other band moved to the Northwest Iowa. Then the band was moved from Iowa to Minnesota to South Dakota and back to where they currently reside in what is called the Winnebago Indian Reservation, which was established by the treaties of 1865 and 1874. The Reorganization Act, or the Indian Reorganization Act in 1934 considered them a federally recognized tribe. Next slide. So this map allows you to see the movements, the relocations, and ultimately the land transfers over the course of the time. And as you can see, there was a lot of movement during a short amount of time with a lot of tribal members dying on those journeys and finally moving to where they are now in Winnebago, Nebraska. Next slide. The Winnebago tribe of Nebraska has a total enrollment of approximately 5,277, with 1,744 living in Winnebago and approximately 495 living in Sioux City, Iowa. The Winnebago Public Health Department primarily serves those on the Winnebago Reservation. As you can see by this map, we're roughly 20 miles southwest of Sioux City, Iowa, about 90 miles from Omaha, and about 110 miles from Lincoln, Nebraska. Next slide. So over the years, numerous efforts have been made to reach health equity for American Indian Alaska Native people. Many are built on the commonly used model visual representations in the panels to the left. This model uses the metaphor of a game, and we've seen this yesterday with Dr. Warren, to symbolize health, and the fence as limiting the ability of individuals to see and participate in the game. It recognized that because of the institutional and structural barriers, giving equal access does not allow everyone to see the game, but instead to reach equity, we have to give those who need it more boxes or services and resources to see over the fence. However, in Indian country, very few of these efforts have seen any success. Next slide. You may be looking at this picture and thinking, what does this have to do with public health accreditation? It has a lot to do with our public health accreditation because it has a lot to do with what we are facing in our community. Our history, Kill the Indian, Save the Man, by Captain Pratt, Carlisle Indian School founder. Only by complete isolation of the Indian child from his savage antecedents can he be satisfactorily educated. John B. Riley, Indian School Superintendent in 1886. As Dr. Warren spoke about this is not the distant past. This is our grandparents and our parents. Next slide. The reservations and colonizations had devastating impacts on our people that we are still facing today. The main goals of Indian reservations were to bring Native Americans under US government control. They wanted to minimize that conflict, encourage assimilation to the settlers' ways of living, forced religion, reduce hunting, and providing subsidies, the commodity programs with high in salt and sugar. Unfamiliar with the reservation lands, since these are not our homelands, didn't know how to grow or hunt on these lands, and unable to leave the reservation without permission. They could not hunt or find alternate resources for the people at that time. Next slide. This picture paints the devastating effects on our food structure. Many indigenous people survived on the bison. This picture shows the devastation on those food structures. In the 1800s, the bison were slaughtered from almost 60 million to as low as 541 in 1890. The numbers are growing, but clearly not 6 million today. Next slide. The boarding school was another impact on our people. As Dr. Warren described, these pictures demonstrate the loss of culture, language, family structure, tribal structure. Between 1880 and 1902, 30,000 Native American children were placed into boarding school. Next slide. Carlisle Indian School. Oh, did we go back? Oh, here we go. Carlisle Indian School was a military school. Uniforms for boys and girls, or boys and dresses for girls. They had regular drill practice and children were ranked. Imagine being taken from your family, then cutting your hair, changing your appearance by changing your clothes. You couldn't speak the language that they were talking to you in. You couldn't speak your own language for fear of being abused. And you only seen your family for a few months, if that was even allowed, if you were even allowed to go home, if you even made it to go home. And then subject to alternative religion, and as well as many forms of abuse. Next slide. The Dawes Act of 1887 allowed for the surveying and dividing into the plots for Native families. A Native family could receive 100 acres to farm, 80 acres to raise cattle, 40 acres to live. This remained into effect until 1934. So this ultimately dictated what you could do with the land that was unknown to your family. Many were in desolated places that non-Indigenous people did not want until some natural resource was found on it. Next slide. This poster is from the National Archives. It shows that in 1910, the Department of Interior sold under sealed bids allotted Indian land. So basically, non-Indigenous folks could get a home, pay it off in no time, and not worry about those Indigenous people that live there. We'll move them. Next slide. This map shows the results of the Dawes Acts. In 1850, then we moved to 1865, 1880, and 1990. And I think this picture really conveys the reduction of the lands. Next slide. The 1924 Snyder Act granted US citizenship for Indians. So the first people of this country was granted to be a citizen finally in this country in 1924. In 1948, Arizona granted voting rights for Indians. And in 1962, New Mexico was the last to grant voting rights to Indians. 1962 is not long ago, when finally Indigenous people were able to exercise their right to vote for people that represent them. Also, this is a reminder of this being an equity conference. that the water rights were given to voting citizens as early as 1900s to settlers and farmers. But yet we still have 30% of Navajo homes have no running water today. And this is not only an issue for our Navajo relatives, but for many tribal communities that still don't have this basic necessity today. Next slide. The Indian Termination and Relocation Act of 1950. This law is really the reason why we have urban Indian centers, urban Indian health centers exist and are funded today. These Indigenous people were promised a good job, a happy home, and training. This is another example of Indigenous people being asked to assimilate into the Western society. They were given initial funds, and then when these dreams were not realized for many, now they're in unknown land with no support. Next slide. The Indian Health Service was assigned the mission to provide health care for the Indigenous people of the United States. Even after legislation designed to protect women from forced sterilization was passed in 1974, the abuse of sterilization continued. Between 1970 and 1976, only for those 6 years, think of that, 25 and 50% of the Native American women were sterilized that came in to Indian Health Services hospitals. 2 15-year-old Native women went into the hospital for a tonsillectomy and came out with tubal ligations. Another Native American woman requested a womb transplant, only to reveal that there was no option because her uterus had already been removed. A Cheyenne woman had her fallopian tube severed, usually being told that they could be untied again. 25 to 50% of the women. It's actually amazing that I'm here today because this is my generation. This is my mom that could be affected by this legislation. This was not long ago. Next slide. So now we come back to looking at health equity. We're looking at it from a different view. We look at this picture, we believe that health equity will be achieved when our efforts are grounded now in our culture and traditional knowledge systems. So we need to break down the fence, recognize we are not and should not be looking at the same game, health. We lift our eyes to the land, put our feet in the water, reclaim our health in the cultural, rigorous way. In this graphic, the woman has broken through the fence, but she's taken the pieces to build a cradle board, traditional method of infant safe sleep, and is keeping her eyes on culture and tradition to guide the wellness of the next generation. So in taking the pieces of the fence, we recognize there are great strengths to Western science and health equity efforts. We can use it to strengthen our traditional knowledge systems. However, we cannot be grounded in it. Our interventions cannot be based in cultural rigor, requires us to first be grounded in our own way of knowing, recognizing the answers that lie within our cultures, and that our resiliency is based in taking action to improve the health and well-being of the future generations. And that is self-determination needed to be in the true change. Next slide. So the Indian Self-Determination and Education Assistance Act of 1975, authorized the Secretary of Interior, Secretary of Health, Secretary of Education, and other government agencies to enter into contracts with and make grants to federally recognized tribes. Now remember, this does not include some state recognized tribes. Many healthcare services that are operated by the government, Indian Health Services, are now operated by the local tribal communities through this act called 638 Contracts Compacts. Next slide. The Winnebago tribe of Nebraska entered in a Title V compact under the Indian Self-Determination Education Assistance Act. In order to be eligible, the tribe had to successfully complete a planning phase, request participation in tribal self-governance, and then demonstrate 3 fiscal years of financial stability and management. So what does this do for us? It allows us to have more flexibility in redesigning and redirecting the funding without Indian Health Services approval. Next slide. On July 2018, when the Winnebago tribe compacted with the Indian Health Services to manage our entire healthcare system. Next slide. This is where the Winnebago Comprehensive Healthcare System was created. This is an overarching system that encompasses both the 12 Plans Unity Hospital and the Winnebago Public Health Department. Next slide. The slide shows the organizational structure, starting with our Winnebago Tribal Council that oversees and selects the Winnebago Comprehensive Healthcare System Board of Directors. The Winnebago Comprehensive Healthcare System, under that is our Chief Executive Director, and then what I like to call the 3 sisters, the Chief Operating Officer that oversees the hospital division, the Chief Administrative Officer that does all of the shared services that we share between the hospital and the health department, such as IT, HR, public relations, and then of course myself, the Public Health Administrator. Next slide. So this shows all of the Public Health Department programs that we have now today and the services. And I have the pleasure of overseeing all of these 15 field health programs. Next slide. Public health has been defined as a science and art of preventing disease, prolonging life, and improving quality of life through organized efforts and informed choices of society, organizations, public and private, communities, and individuals. I have always loved the story that Dr. Worm says about public health, and he describes it as this. There are 3 sisters walking along a river. One of the sisters starts to notice that there were babies floating down the river. She runs over there and she starts grabbing the babies and starts to put them on the bank. The second sister says, we need to teach those babies how to swim. Then the third sister, she starts running up the stream, and the other 2 sisters start yelling at her, where are you going? And the sister says, I'm going upstream to find out who's putting those babies in the water and stop them. And that's the essence of public health. We are upstream. We are trying to influence everything and everyone before they float down the river. Next slide. For thousands of years, before European contact, Indigenous people had their own systems of care throughout the lifespan that integrated spirituality and all of the nature in the universe. This is still our way of being. We have doctors, psychologists, bone specialists, midwives, pharmacists, forms of governing and justice, and systems of community and family support. They just might not be titled what you might see in the Western society. Next slide. Public health accreditation has as many know, is the measurement of a health department's performance against a nationally set of standards, recognized, practice-focused, evidence-based standards that allows for continually development, revision, and distribution of public health standards. The goal is to improve and protect the health of the public by advancing the quality and the performance of our tribal public health department. Next slide. And as many of you know, there are 7 steps in public health accreditation. There is pre-application, application, document selection, submission, site visit, accreditation decision, reports, and re-accreditation. Right this minute, we are still in the pre-application phase, but our goal is to submit this September. Next slide. And of course, there are 12 domains. Conduct and disseminate assessments focused on public health status and public health issues facing the community. Investigate health problems and environment, public health hazards to protect the community. Inform and educate about the public health issues and functions. Engage with the community to identify and address health problems. Develop public health policies and plans. Enforce public health laws. promote strategies to improve access to healthcare, maintain a competent public health workforce, evaluate and continuously improve processes, programs, and interventions, contribute to and apply the evidence base of public health, maintain administrative and management capacity, and then maintain capacity to engage the public health governing entity. Next slide. So where did we start? We started with hiring an accreditation coordinator. She completed all the PHAB's online orientation. Importantly, she sought after grants, contracts to help support all of the work, and she keeps all the data and us on track. We received support from leadership, myself as the health administrator, the WCHS board of directors, and the CEO, and the tribal council. Next, we formed an accreditation team, and this ranged of experts within our health department. Next slide. So our first task was developing our strategic plan. So we hired a facilitator that had already worked with Indigenous nations seeking accreditation, formed a strategic work group that met off-site for about 4 meetings. This really set the foundation for what our goals and strategies would be for the next 5 years. We continue to do a review semi-annually just to make sure that we're still on track, even though COVID did divert us just a little bit. But it's a living document that should not sit on the shelf and collect dust. Next slide. Our strategic plan was adopted by the WCHS Board of Directors in 2019. And we provide reports on an annual basis on the progress. We're currently developing a workbook that will be able to measure our successes so we can report continually to the Board of Directors, but also to our stakeholders so they know exactly what their public health department is doing. Next slide. Through our strategic planning efforts, we developed our mission and vision statements. So the Winnebago Public Health Department strives to create and maintain a healthy community. Our health department will be proactively and proudly serving the evolving needs of our community. Our staff members will take pride in their work, model healthy behaviors, provide culturally centered, appropriate services, and excellent internal and external customer services. So at the base of all of ours is culture. So we need to remember our culture as we plan and move forward with anything that we're doing. Next slide. So as we were continuing our strategic plan efforts, we debated and wrote many things. At the end of the day, we decided that the 10 essential public health services by the CDC really encompassed everything we wanted to have in our public health department, that we wanted to have, what we will do, and what we can achieve. And so we're looking at the assessment, the policy development, the assurance, and then of course at the middle, equity. Next slide. So then we began to work on our core values. We wanted to make sure that the ideas encompassed our wants and wishes for our staff to convey. So we started with respect. We wanted to make sure we had a high regard for feelings, wishes, rights, and traditions of others. Our cultural sensitivity. Our culture is a part and ingrained in our public health department. We needed to make sure that those that work for us are aware of the cultural differences and similarities between the people exist without assigning them a value, positive or negative, better or worse, right or wrong. Because even within the culture, there are different divisions. And so we want to always be respectful of all of those. Confidentiality. We wanted to make sure that keeping another person's or entity's information private is at the utmost importance to us. We are a very small community. A lot of the community members work for us. And so we wanted to make sure that confidentiality and now professionalism, having good judgment and polite behavior, was at the forefront of what we wanted for our health department. Next slide. Culture and incorporating it into our program planning, as I have described, is the utmost importance to us. In our planning, we also remember that our strength of our people is found in the resilience of our people, which can be found in our culture, prayers, sacred places in nature, ceremonies. And this is one of the reasons that we have survived all of the history that I have presented before. Next slide. Our strategic goals were identified as the following. We strengthened workforce development efforts. We really wanted to make sure that we were developing our current workforce, but we're also looking to our children. We wanted our children to be able to replace us, to be able to come into our healthcare and be able to perform those services. We also wanted to develop strategies to increase our resources. We wanted to make sure that we continue to expand the services, improve them, and meet the needs of our people. We wanted to improve work environment to foster growth. We wanted to empower our people to increase their knowledge and training, but also at empowering our children and getting them into the healthcare field as well. We wanted to increase the profile and identity of the health department. We wanted to make sure that the community knew that all of our programs are under one umbrella. We wanted to create and implement a performance management system to make sure that our programs are setting goals, achieving those goals, using data, and constantly improving ourselves. And then we wanted to improve the fiscal resources by providing budgeting, grant classes for our staff to have a better understanding of the fiscal responsibility. And then our final one was a unified healthcare system. We wanted to work and partner with our sister, the 12 Clans Unity Hospital, to better support one another as we move through working on the health impacts of our people. Next slide. So now we got the strategic plan done. Now we're working on the community health assessment. So we needed to find our baseline and what is going on in our community, gather the data. So we chose to use the Indian Community Health Profile process. And you can see the process if you're pretty similar to MAP. Unfortunately, there sometimes is a lack of local data in some areas, but we did find primary and secondary data that we were able to use. It was also difficult sometimes to find where things were located and who had access to what. But once we collected the data, we needed to find now a contractor to analyze. And then once he analyzed, we needed to determine what we wanted to get out of it. There were several reviews of this information. I think we even changed course at one time, and then we got back on course. But we got a document that we could use, needed to determine the need and we needed to report back to our stakeholders. The WCHS Board of Directors adopted it in 2020. We then presented it to the public health directors, the community, and it's currently available for anyone to review in our health directors' offices. Next slide. So now that we were done with the community health assessment, the real work is now to begin. The Tribal Community Health Improvement Plan work is to be started. Again, we looked for a facilitator. The T-CHIP work group was selected, and these were members from the community programs, health employees, and the group identified 5 priority areas. And then they got down to 2: healthy living and behavioral health. We needed to identify our current resources, which are vast, then look at those gaps that we have and do an analysis. The large work group turned into 2 separate work groups. They started to make tasks. They selected the important data points from that community health assessment in order to make outcome objectives and a work plan. Next slide. Then the T-CHIP was finally completed. We presented it to the WCHS Board of Directors, and it was approved in 2020. And of course, these are all living documents. We have quarterly meetings, and the subgroup tasks between meetings, they work together. We continually try to add community stakeholders that are interested. And we're really trying to look at these approaches through a strength-based and Indigenous lens. Next slide. The emergency operations plan had the foundation work done back in 1997, when, of course, some of you may remember the bird flu or the avian flu. So we dusted off our plan. We started to use it in 2020 in response to the COVID-19 pandemic. It really outlined the communications that we would use and the stakeholders that needed to be brought in together in order to put it together. The legal authorities that were responsible for the implementation, the logistics of housing, alternative site locations. The WCHS Board of Directors adopted that in 2020. We started meetings back in March of 2020. And this also helped with the vaccine response. It outlined the priority areas. It really took the guesswork out of who we needed to vaccinate first and how we would proceed to the next group. The emergency operations plan really laid the foundation so that we could properly respond to the pandemic. Next slide. In our work with some of the other tribes, we decided we would combine our quality improvement and performance management plans. Again, we selected a contractor to help guide our work. We established a QI work group that consisted of staff roles and responsibilities. We conducted a self-assessment, and then we found out what training our staff needed, what selection of the QI projects we wanted to do. And so we selected one was our client satisfaction survey, because it really is so important for us to get information back from our people to create and change the plans that we're doing to really reflect what is needed in the community. The other one is a wellness in the workplace. Since our workforce is in the tribal organization, is the majority are community members, we thought it was important to make effective change by going to the places where people work and work out with them for maybe 15, 30 minutes a day. This breaks up the day, gets the people moving. And already, just starting this year, they've already seen some changes with the people they're working with. We also did some training on our PM measures, so our performance monitors. We did line of sight to the plans. We made sure each program is working on at least 2 projects. Each of the health directors reports on these quarterlies and creates an action plan of how to get from red, which is bad, our baseline, to the yellow, which is better, and then ultimately to the green, which we would like to see in all of the programs. And these PM measures are really looking at all of the plans that we have created. It's either drawing back from the community health assessment, going back to the tribal community health improvement plan, looking at our strategic plan, looking at the priorities of the people. And so in each of the PM measures, we really remember going back to what is significant in our community. Next slide. We have been working on developing our communications plan. It is fortunate for us that we have a communications officer that is able to help coordinate with our accreditation specialists as well as our public health associate on all of this work. We had to create a branding strategy. So basically, everyone needs to use our approved logo before any of our flyers, t-shirts that we all like to do in public health, or any of the other material needs to have our approved logo. And as you can see, the logo from the side, this is our approved logo, and it is very unique to us. Our logo consists of a Winnebago tribe chief named Whirling Thunder. He was significant in making sure that in our treaty, there was a physician and a building so that the people's health was at the utmost importance. It is also surrounded by a 12-point star. This represents the 12 clans of the Winnebago tribe. And as you can see around the image, there is a circular applique pattern, which is distinct to many, to the Winnebago tribe of Nebraska, but also to others. The Winnebago Public Health Department's name is at the top of the circular pattern. And then we have the yellow, green, which is the earth, and then the teal, which is sky colors in the logo. This also represents the Earth and the Sky clans. And we included a contact list of media and stakeholders, strategies for internal distribution. We made sure we had public relations strategy. It is important to have our public health violations, public health emergency notifications, and where to find everything. So this was really important when it came to COVID-19 and how we responded to the people. We wanted to make sure that the people were getting the information directly from us. So we made sure that we had lives, Facebook lives, recordings, information, flyers, all of that stuff in order to get the information out to the people as best as we could in whatever form that meant. And sometimes it's more difficult at times to get information out to all of our membership. But we of course did the best we could, but this really was instrumental in doing that. The next slide. Of all of the plans, this has to be my favorite, the Workforce Development Plan. We started by conducting training with the directors, our health directors. Then we did a survey with the staff that asked them about age, race, professional degree, and retention. And they probably thought we were just being nosy, but it was really important for us to know what our public health department looked like, because a true public health department should reflect what our people look like, and ours do. And I'm proud of that. They also wanted to make sure that we were retaining our health department employees. So this led to also training with the staff. We selected health competencies with each of our health directors as well as our staff. And we wanted to make sure that we enhance those through orientation, annual and individual training plans. We added all of those those health competencies to their job descriptions. And now we will be enhancing those with training. We also selected a workforce work group, and they selected a bunch of training that will be outlined in the plan. And the staff have also identified training that they would like to work on in the next year. And so we're all looking at implementing all of this to make sure that we are creating a more improved workforce by providing the public health training that they're asking for, that they would like to have, but also empowering them to be able to select individual training that will enhance their abilities in whichever direction that they are trying to go into. Next slide. So we have a lot of accreditation activities going on all the time. So it's important because it needs to be ingrained in our work culture. So we have weekly domain meetings. So we're looking at all of the domains, making sure that we have the appropriate information or backup that we will need and want to be used. It's also important to present information in our monthly all staff-wide WCHS meetings. Then we decided that we wanted to really focus on some of the accreditation messages. So we decided to start having monthly, specifically Winnebago Public Health Department all staff meetings. We also send out, just in case you're unable to attend the all staff meeting, all staff updates. So it's important that they receive emails from my office as well as from the other directors. They really need to hear what is going on with our accreditation process and what is their role in it, because they are vital to the success of our accreditation, but also not only that, but the success of our department. We created a OneDrive, so all of our staff have all of the policies and procedures from all of the departments. All of the job descriptions for everyone are located there. All the accreditation plans that have been adopted, the branding toolkit, and all of the individual departments' brochures. Because it's important that nothing is kept secret from our people. They need to know what we are doing, because we're a team, we're a family, and we need to work together to overcome many of the issues and health impacts that face our people. Next slide. So just to recap, in 2019, our strategic plan was adopted. We're still working on some of our policies and procedures, but we're sure that they're going to be done in September. In 2020, our community health assessment was adopted. Then in 2020, our emergency operations plan was adopted. Also in 2020, our tribal community health improvement plan was adopted, focusing on healthy living and behavioral health. And then in 2020 as well, we did a lot of work while we were in quarantine and isolation. We also got our quality improvement and performance management plan adopted. Next slide. So of course, we still have some things to do. So we're going to be working continuously on our workforce development plan, is right now in the draft form, but we're going to be getting that very shortly, because now we have all of those wonderful trainings that the work group has put together and others in order to make it a very comprehensive plan, but also the trainings that our people have been asking for. And then as you see, our communications plan is also in the draft form, but it's pretty close to being submitted so that we can get that approved by the board. And of course, all of this needs to be completed, or we would like it all to be completed by September of this year so that we can apply for our public health accreditation. Next slide. So some of the challenges that we had. So staff time, even though we have an accreditation specialist, we still all have to work on different aspects as we're trying to keep focus on our accreditation efforts and making sure that we are including all of our stakeholders. We want to make sure that this plan this accreditation efforts were for everyone. And it's kind of hard, especially during COVID, to try to get people all together. So a lot of our staff were working on COVID response, COVID vaccines, but yet somehow we were able to still come together and continue our important work on accreditation. We also wanted to make sure getting buy-in from the staff. So we've been doing this for approximately 3 years. So we're really reaching the staff is so important. We have our monthly health directors meeting, but we wanted to do more. So we're constantly trying to reach the staff so that they understand what the work that they're doing is so important. And really accreditation is just highlighting the importance of their work. So we're not trying to add to them, we're just trying to enhance what we're already doing. And so we constantly are trying to get buy-in from the staff to show how important this is. And then funding, I think, is always an issue. Our accreditation specialist has been able to find a variety of resources for us to support our work. Because as I'm sure all of us know, evaluators and contracts are not cheap, but they are so helpful. It is so important, especially in this first round, that we understand and have a good understanding and grasp of what is expected of us. There are not very many tribal health departments that are accredited. I believe the number is under 5. So this is why it was so important for us to put our best foot forward. We wanted to make sure that we were working with our evaluators, our contractors, so that we made sure that we had everything in line. So when we come to September, that we will have all of it ready to go. COVID-19 did put a stop in much of our work, I suppose, in public health, because we had to refocus. We had to take care of our people. We had to respond to the pandemic. We had to educate our people. We had to try to protect our people. So many actions took place during the pandemic. But what wonderful examples that we had from that now that we can use for public health accreditation. We established a hotline. We were able to provide for our quarantine and isolation families. We created laws in response to the pandemic that now that we can use going forward. We were able to provide housing and follow-up for our people. So even though COVID-19 has become a hardship at times, we were able to overcome, as many of you have seen, the resilience and the strength of our people of being together, working together, and really supporting one another. Finally, cultural considerations. Now, I put this as a challenge, but technically I do not see it quite as a challenge. I see it as our unique sovereignty. But the accreditation standards sometimes have languages that we need within it that we need to constantly push back on, because we do have a unique relationship. I think that you've noticed in the beginning that it's important for us to know who we are and where we've come from, and include that as we move forward. We make sure that we keep our culture and our traditions and everything that we do. You know, we're pretty proud that our population at the Winnebago Public Health Department is made up of 75% Indigenous people. So our workforce does look like the population that we serve. And we're proud of that. And we want to continue to promote that. We want to have good relatives with our non-Indigenous people that work for us. We try to encourage inclusive and equity for all. But our traditions and our culture is always at the forefront of what we do. Next slide. So I would like to thank all of you for attending today. Thank my staff for the hard work and determination that they had, not only in the last year, but over the course of our quest for public health accreditation. And I appreciate you spending some time with me today.